Thank you. So I will present today the update that was presented actually on during the ESC Congress, but at the same time there was a very important paper that has been, or a study that was presented, that is the STEP-HFpEF study with semaglutide, that unfortunately, given that it was presented late, was not included in this update, and that will be part of a separate document of the Heart Failure Association, given its importance. So, since the publication of the 2021 guidelines, there have been several documents that were very important for the update on heart failure. So, of the overall publications, we have to consider that all the meta-analysis and randomized clinical trials have been published until the 31st of March 2023, but only those that led to a change in the guidelines, so only for those were related to class 1 or class 2. And it was important that a 75% of agreement was needed in order to have a recommendation. And more than 75% of the task force has agreed to what I will be presenting today. So the three areas where the guidelines focus are chronic heart failure with the mid-range and preserved, the acute, and the comorbidities. Now, regarding chronic heart failure, do you know that we, in 2021, we gave a class 2B for mid-range for ACE inhibitors, ARBs, beta blockers, MRAs, and sacubitril valsartan, just because of the absence of any clear data and study in patients with left ventricular function between 40 and 50%. And also, we didn't have any study in patients with preserved ejection fraction, and therefore the class 1 was just for screening for etiologies and treatment of the etiologies. So that became outdated 4 hours later, because it was presented in the morning, and in the afternoon the Emperor Preserved was presented, and the Emperor Preserved basically changed the practice in preserved heart failure. That was followed the following year by the DELIVER study with dapagliflozin that demonstrated a similar 20% reduction in heart failure hospitalizations and death. And therefore, they made a big case for the SGLT2 inhibitors to be recommended in patients with left ventricular function between 40 and 50%. You can clearly see that then a meta-analysis of the two studies demonstrated a 20% reduction in cardiovascular death or hospitalizations for heart failure, a reduction of cardiovascular death, hospitalizations for heart failure, and that these effects were consistent throughout all the different left ventricular function subgroups, in those with 40 to 50, but also in those above 50%. This therefore has had an impact on the recommendation for the guidelines for both mildly reduced and preserved. In mildly reduced, the SGLT2 inhibitors, dapagliflozin or empagliflozin, are recommended to reduce the risk of hospitalizations or cardiovascular death. And therefore, looking at the management, you can see that now we have a class 1 for diuretics in case there's a fluid retention, and then dapagliflozin and empagliflozin, and then a class 2B for all the other classes of drugs. That means that the priority is to use empagliflozin or dapagliflozin. Only after they've been implemented, then you can use the others. For patients with left ventricular function greater than 50%, then again, the empagliflozin or the dapagliflozin are recommended to reduce the hospitalizations and cardiovascular death. Again, diuretics, again, class 1. If there is a congestion, then dapagliflozin and empagliflozin. And then the treatment for etiologies, and both cardiovascular and non-cardiovascular etiologies. And for that, you should refer to the position statement published by the Heart Failure Association in May this year. Regarding acute heart failure, we had a generic recommendation to follow up patients after discharge from after the acute phase. So there have not been any new trials on the acute phase, but then there's been a study on the management of patients immediately after the acute phase, and that was the strong HF. The strong HF basically used a very close follow-up of patients immediately after discharge. Is a follow-up that I'm not sure it can be implemented everywhere in all the different settings, because it required contacts every 2 weeks and follow-ups guided by natriuretic peptides. But this approach was compared to the standard approach, and the high-intensity care led to a significantly higher up titration of ACE inhibitors, ARBs, beta blockers, and MRAs, and led to a 20% reduction in mortality and hospitalizations for heart failure. Therefore, we took those results into consideration, and we gave a class 1B recommendation for an invasive strategy of initiation and rapid up titration of the evidence-based treatments before discharge and during the post-discharge period for the following 6 weeks. So a full up titration that should be implemented within the first 2 weeks. 6 weeks. So regarding the comorbidities and prevention of heart failure, we focused mostly on type 2 diabetes and CKD and iron deficiency. We have data with the SGLT2 inhibitors trials, both in type 2 diabetes, heart failure, and CKD. And the SGLT2 inhibitors have been analyzed, and all the trials have been analyzed, and they looked at the effect on diabetes that was overall effective, as we know, but also in patients with CKD, you can see that there was a dissociation of the effects, with the SGLT2 inhibitors being very effective in reducing events in patients with diabetes, less effective in those with chronic kidney disease without diabetes. So that basically gives a strong indication for the use of the SGLT2 inhibitors for the prevention of the progression of CKD in patients with diabetes, but not in those without diabetes. On the other hand, we had other trials, always again in diabetes and CKD, with finerenone, that is a non-steroidal MRA. These were the Fidelio and Figaro, and their analysis was, the pooled analysis is the fidelity. So the study and the meta-analysis, demonstrated a significant reduction in the hospitalizations for heart failure in patients treated with finerenone, and the effect on the composite outcome. Therefore, taking this wealth of data together, we updated the indication for type 2 diabetes, for the use of SGLT2 inhibitors in patients with type 2 diabetes and CKD, to recommend to reduce the risk of heart failure hospitalizations and cardiovascular death. And in patients with type 2 diabetes and CKD, the use of finerenone to reduce the risk of heart failure hospitalizations. So this is for prevention. So these are the main recommendations. And then the last one is on iron deficiency. Regarding iron deficiency, we gave a class, in 2021, we gave a class 1C recommendation for screening of patients for iron deficiency, and a class 2A for the supplementation with ferric carboxymaltose to alleviate symptoms and improve exercise capacity, and again 2AB to reduce the risk of heart failure hospitalizations. These were based mostly on the AFFIRM-AHF and FAIR-HF studies, but then more recently we had the data from the Ironman. Was conducted a study, was fully sponsored by the British Heart Failure Society, and it was that was conducted with derismaltose. And the data of the Ironman were basically in line with the AFFIRM-AHF. At the same time, also the FAIR-HF had been stopped because of the COVID pandemic. Sensitivity analysis being conducted. When the studies were put together, you can see that there was a clear effect for intravenous iron in three meta-analyses that gathered consistent results in order to reduce the hospitalizations for heart failure, less so for mortality, and therefore we changed the recommendation in class 1A for the use of IV iron in patients with both REF and MREF, so up to 50% of left ventricular function, to alleviate symptoms and improve quality of life. So, then we left a 2AA for the use of iron supplementation with ferric carboxymaltose or ferric derissomaltose to reduce the risk of heart failure hospitalizations. This is because the data are very consistent. So we see that our treatment with, and the landscape of treatment with patients with heart failure is changing. And I think in the future, what we'll have to do probably is not to look at heart failure as silos, but look more as a continuum and look at the trajectories of patients across the left ventricular function. We now have drugs that work, the SGLT2 inhibitors that work all across the left ventricular function, whilst the neurohormonal modulation has been the mainstay of our treatment for the past 30 years. Now probably we'll have to be limited only to patients with reduced or at least up to a left ventricular function of 45%, but not more. And also on the horizon, we have the effect of the GLP-1 receptor agonists that have been shown to be clearly effective and recently demonstrated a significant effect reduction in mortality. So we'll be still in business for long, and I think it's the new guidelines have made a major step in improving the treatment of our patients with heart failure. Thank you very much for your attention.